I would like to make a comment here. It's absolutely true that we have been running large trials that have established this drug as a very important drug for women with this disease. However, we know that not all women benefit from it. And because of probably suboptimal translational research, we are unable to tell which are these women. So today, in rich countries, every woman with this diagnosis receives trastuzumab. There are still questions whether it should be given after chemo or combined with chemo. But there is this very important question about the duration of the treatment, which is not solved today. So, and that brings a problem because, you know, there are many women in the world who cannot access this drug. Probably in low-income countries, only 5% of women with this disease can access the drug because they have money. And that, I think, is extremely frustrating and indicates to me that we will need to think about new ways of doing these trials. They are currently done for the rich countries. The duration of a targeted drug is key. You know how we pick it up? Randomly. We just thought that 1 year would do it. But in fact, we don't know. It's possible that you could get the same results with a much shorter treatment. It's very difficult now to ask these questions a posteriori. You know, now that we know that the treatment is so effective, there is perhaps a small risk in, you know, going into a study investigating a shorter duration. Now, these trials are being done in UK, in France, in several parts of the world. We may get an answer, we may perhaps not get an answer. And again, I think it's our responsibility in the future perhaps to start thinking a little more into this important question about accessibility to these drugs. The way we conduct the trial are going to dictate the way the drugs are used. And of course, I understand, you know, the pharmaceutical industry is running these trials with us. They are very expensive. And you have to make a kind of bet. So you will go for the 1-year treatment, and you will be uncomfortable with exploring 2 months. There was a small study that was not supported by the companies that have this drug Herceptin that investigated only 9 injections. Very small study, positive. And now we are there with these results, and of course, because it's a small trial, we are uncomfortable, you know, to start saying that this is equivalent. So it's a very interesting story, the story of trastuzumab. We still don't know who doesn't benefit. We prescribe 1 year of treatment. Maybe we could do with much less. And I think there are lessons to learn out of it at an international level.
So the international issue, in keeping with our theme, of course, is that if we knew that 3 months of trastuzumab Herceptin was sufficient, we could treat 4 times as many people with the same investment. That's one critical point, and that would be a way of sharing the benefits of this drug more broadly. Now, I think your question was as well, after that first year or two, if somebody finds out that they had HER2-positive breast cancer and say half a decade later, we've made this discovery, why might we not bring them back in and now give them trastuzumab? And to answer that, we're going to ask another one of the principal investigators on the BCRF-funded trastuzumab trial from North America, the North Central study. This is Edith Perez. And by the way, she's actually from the U.S.
Puerto Rico originally here. Pleasure to be here today. I'm sorry to be turning my back to you guys. 3 very quick issues related to this excellent question. Number 1, a trial has been finished in terms of accruing patients who were diagnosed with breast cancer a long time ago, whose tumors were HER2 positive, who did not receive Herceptin, and it was done with a drug called Tykerb or lapatinib. So we're now actually waiting for the results of that trial because people thought that this was an important question to address, and it's very good that the trial has already completed accrual. That's one issue. Number 2, you know, will it work or not work? We have to wait for the data. But it may be that for anti-HER2 drugs, because these tumors tend to be aggressive in their growth pattern, it may be most important to use these drugs early after a diagnosis of breast cancer. And that's why we have all done studies looking at whether we should use the Herceptin concurrent with chemotherapy or sequential with chemotherapy, which is a second issue that has been addressed. And I'm very pleased to let you know that with the help of BCRF, with the help of the National Cancer Institute and many investigators, we actually conducted the trial to answer this very important question. And I'm also very pleased to let you know that in the next few months, we will be able to share this data with everybody, because it's a central question. Should we use it concurrent or sequential? And we will have the information to share with the world very, very, very soon.
And
with your help.
So one of the things that you get out of this is that we have the charge to both help and do no harm. And in your question, why not bring everybody back and give trastuzumab years later is, and everybody said this, but I just want to highlight it, is we don't know that it's beneficial applied years later, but we do know that like any treatment we ever give anybody, there must be some, in this case, very small risk of side effects. And there's a financial risk, frankly, to imposing an untested, expensive therapy on a lot of people. So people are wondering why their doctors don't just bring them in and do this. The answer is there's not any evidence to do it, but with the study that Edith described, there may be one of these days. Now, I think Eduardo wanted to add another comment, and then we'll come back to you, Martine, and then Larry.